Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. This podcast is about Right 7.8 from the Health and Disability Commissioner Code of Rights. And the question is, can patients specify who looks after them? Because we need to balance patient requests and workplace obligations. My name is Chow Yen, and I am a medico-legal consultant at MPS and an anaesthetist for Te Whatu Ora. I'm very lucky today to have with me Sarah Dalton, Director of the Association of Salaried Medical Specialists, ASMS, Dr. Sam King, Fellow MLC and GP, Dr. Tim Cookson, recently retired Fellow MLC and GP, and Adam Holloway, who's one of the partners at our panel law firm, Wotton and Kearney. Hello, everyone.
Hi, Chayan.
Kia ora.
Hi, Jan.
We've had some members phone in and ask us whether patients are able to ask for providers of a certain ethnicity not to care for them. Our advice has always been to inquire about the reason for the request. Generally speaking, the answer should be no. Patients cannot choose the ethnicity of their healthcare provider. So there's an article published by Roger Klein, and he wrote an opinion piece in the BMJ about this. I'd like to just read an excerpt of an example he gave. Glasgow GP, Punam Krishnan, described how a patient saw her in reception and then asked for an appointment, but not with an Asian doctor. The practice receptionist said, "She's Scottish." The patient replied, "She doesn't look Scottish," to which her receptionist asked, "What do Scottish people look like?" Silence followed, and then an appointment card was taken.
That was such a great response, wasn't it, from the
Yes,
receptionist?
that's right.
Absolutely brilliant.
I've had a colleague tell me that while in the UK, he was addressing a patient from India's request not to be cared for by staff from his own ethnicity. My colleague has blonde hair, but explained that his grandmother is Rajasthani. The patient said to him, "3/4 white is all right."
Excellent.
Excellent.
So when does it not become all right? At
That's
what proportion?
right.
Yeah.
This appears to be a spectrum.
Yeah.
Of course, this just doesn't just happen in the UK. My anaesthesia colleagues tell me that recently they've had a request for a Kiwi anaesthetist. So whether our immediate response is a humorous one to diffuse the tension, because it is highly, highly uncomfortable, or to directly address the discrimination, the issue is having our ability to do our jobs judged based on the colour of our skin. This affects us all. Sam, how do you think we should approach such a request from a patient? It's not always straightforward, but say a patient says, I don't want to be seen by someone of X ethnicity.
Yeah, it's definitely emotionally charged. Speaking as a woman of colour myself, it's obviously a topic that I feel a little sensitive about, as I'm sure most of us do. I think it's worthwhile exploring with the patient. Is it just a personal preference? Is it perhaps prejudice on their part? Or is it something else? Like, is it a true phobia? For example, if you were assaulted by somebody of a certain ethnicity, often people develop PTSD, they might have a true phobia, and you can understand why they feel uncomfortable and react in certain ways around certain ethnicities. So it's worth exploring that, I think. I think, too, you want to find out if it's about misinformation. I mean, have they heard that, people from a certain country, qualified in a certain country, might have a lesser level of competence, for example. So is it just misinformation that you can correct? So it's worth exploring it with your patient. I think, too, we often think about patient-centred care, but when we're talking about this kind of issue where people are choosing an ethnicity that they want to be treated or not treated by, you've got to think about the staff safety and how that patient is going to treat your staff and whether your staff, in fact, will be safe. And patients who are already thinking, I don't like you because of the colour of your skin, are much more likely to complain. And as often happens, they're the patients who end up with some form of complication or, adverse outcome. And so it can become an issue for the staff in terms of safety, I think.
Yeah.
One comment you said about whether an approach should be humorous to try and deal with this. And I'd probably counsel in this situation that's not a case where you should try humour, because these people will always they'll be worked up about it from the start. Just to mention it, they're clearly worked up about it. And in that kind of situation, my impression is that humour will almost always be misinterpreted, and it'll be a denigration of their position, and may even become the basis for the complaint, which we've seen in other situations. So while humour is often good in consultation, this is one example where I think that could easily backfire.
So a direct approach, clear communication.
Yeah, I think in a comment like, well, we haven't managed to train many Kiwis to do anaesthesia yet, they haven't got the right arms, it would not be a great...
Oh my goodness, Tim.
I think, though, the example that you gave from the BMJ piece was a conversation between a patient and a receptionist. So there's no guarantee that this conversation is going to happen with a GP or with a doctor in the first instance. It's hard to know where or when this might happen, what staff member might be confronted with this very difficult, very challenging situation, and whether or not they actually have the tools ahead of time to understand how to deal with this, what feels like not a reasonable conversation, but certainly a difficult conversation to have, possibly in a more public place than a consultation space, and under pressure of time. So I think it's really important that we think about not only how we might respond and what might be the issues in terms of our obligations and what is the right thing to say, but how do we make sure that the staff that we work with, many of whom won't be doctors, have training, support and opportunities to talk about these issues ahead of time as part of normal professional learning and development, so that to some extent they're ready and it helps them deal with, and particularly if you have this, I imagine it would be difficult enough in the reception area of a busy GP practice, but what if it happened in an ED department in a busy triage area, or in the waiting area for, pre-op clinics or something like that in a hospital?
Yeah, you're absolutely right. And the whole system needs to be prepared to address it. And I know that in EDs, certainly my partner tells me that in his ED, the immediate response, once they've explored what the underlying reason might be, is we only have the staff that we have available here, so you'll be cared for by who is available. So in that situation, they don't accommodate for potentially discriminatory requests.
So that then raises the question, doesn't it, as to, so you've got a patient who is going to be predisposed to complain, as Sam has said. Should the clinicians who might be of that particular ethnicity be notified that this patient has said, I don't want a doctor of X or Y ethnicity? And should they be given the right to say, actually, I don't want to see someone who's already expressed that kind of opinion, because I think I will personally be much more vulnerable to complaint than one of my colleagues who is not of my ethnicity?
I think that's a really difficult consideration, because on the one hand, if it's an emergency situation, we do have to provide care. But what if the only person available is that ethnicity, is a doctor or a provider of that ethnicity? So you can't immediately say, oh, we're just not going to accommodate it, because sometimes it exposes your colleagues to complaint just because of that patient's request. You could consider assessing them, going back a step. That's why I think it's really important for the whole organisation to have a response so that we can be clear about how to move forward to assess this patient's request when they make it. Because like you say, they'll be worked up, it's important to them, and that's why they've made the request. And on the one hand, if we just say blanket, we're not accommodating this discrimination, it then potentially exposes all your staff members of that ethnicity to complaint. But by accommodating it, then you're kind of saying, oh, it's all right to hold this view.
That's a real can of worms, doesn't it?
Say yes to racism.
That's right.
Yeah. And what a precedent to set. So that person then goes home and says, oh, it was great. I said I didn't like Asian doctors and they gave me a white doctor, and that's great that the hospital does that. So,
it surprises me, Jiao Yen, that services don't have guidelines or policies and haven't thought about this in advance, because it's not an easy issue, and it puts an awful lot on the shoulders of clinicians or reception staff to be managing this on the fly. I think that if I were a clinician working in a service where someone had ascertained that a request like that had been made and I fell into the category of objected to doctors or nurses, I would probably want to know. I don't think that it would be a reason for me not to provide care, particularly in emergency, but even if there's no other staff member available, I think you still have an obligation to complete your role and offer those services, knowing the information and knowing that it may expose you to a greater risk. There are patients that are seen all the time who have varying predilection towards making complaints, and doctors don't get to pick and choose who they see just because somebody might be more likely than the average to make a complaint. But perhaps in a service setting like an ED where there are a lot of people on shift, then people can be swapped. I'll see that patient instead of this one, or what have you. But it doesn't seem to me to be the sort of situation where learning that a patient has expressed a racist view, that you can then choose to withhold care for that person. What do others think about that?
So I'm really interested in this. I think having a policy or guidelines is a no-brainer, actually, or a set of protocols that is supportive of staff to have a clue what to do. I agree that knowing that you've got a patient who has expressed a view that is racist or discriminatory in some respect doesn't absolve you of providing care. But I do think potentially, I think it's really important that staff know. So I don't think you should send, say it's an issue of an ethnic preference that's been expressed, or so if you're sending in a doctor of colour, I think they need to know what they're going into. And I think potentially there needs to be another member of staff who's able to be in there with them as a support person, whether they're able to also help deliver care or whether they are simply there to make sure that that staff member is safe and that any interactions that take place are witnessed, so that if there is some kind of malicious complaint or an unjustified complaint, it's not just the word of that staff member to say, no, it wasn't like that. So I think there are some obvious things to do. Now, again, when you're in a busy situation, if it's an acute setting, it might be hard to find another person who's able to do that. But I think it's really important that that is put in place to support that person so they can then focus on giving the best medical care without having to second-guess themselves or worry. And that other person could either be taking notes or they could be comforting the patient and saying, I'm just here to ensure that you get the care that you need, and I'm here to, if you've got any concerns, I can assist with those or whatever it is, without undermining your staff member. And, let's be honest, we have nearly 50% of our senior doctors practicing in hospitals are international medical graduates, and an increasing proportion of our nurses are internationally qualified nurses. So they come from all over the place. If we didn't have all of those people practicing in our country, our health system would be in an even worse state than it is currently in. So I think we need to understand, just as we expect people who come here and people also who are studying to become doctors and nurses here in New Zealand, there are cultural safety and cultural competency components of training and professional learning and development. I think it's really important that we return the favour and try and understand what are the things that people who come here bring with them. What do we need to learn about those people and their cultures and the difficulties they face, particularly if they're a person of colour. Those of us who live our lives surrounded and cloaked in white privilege, we need to take a breath and ask some questions, and that's why I think professional learning and support in workplaces preempting these things is really important.
Yeah, so
I agree entirely with the idea of having someone else there at the consultation. What the doctor also needs to be aware of is that just by virtue of the situation, their care for that patient is going to be different. So they're going to probably organise perhaps more investigations than they would otherwise do, and they're going to be practising defensive medicine as opposed to normal medicine with that patient. And there's no way of getting around that, because as soon as you know about the situation, as soon as you know that someone's likely to complain, that is what happens. And the important thing is the recognition that you're doing that, and trying to have some sort of cognitive counterbalance to that tendency to overdo things.
I would like to think that the employer has a concern for their employees in their safety. And so my personal view is that we ought not to pander to our patients' discriminatory behaviour or, their biases, all that sort of thing. But I think if we're going to provide a safe environment for our workers, if I don't feel safe seeing a particular patient for whatever reason, might be an aggressive man or something like that, I want to know that someone else is going to step in my place, and they do not have to be placed in that situation.
Yep. Look, I think safety for hospital staff is going to become more of an issue, not less of an issue. And we've already, the police are starting to step away from staying with patients that they bring in. They're talking increasingly about a 15-minute handover and then they'll be gone. And there are a number of hospitals that rely on contracted security staff. Now, if they're contracted, they absolutely won't be trained in de-escalation techniques. They may not even be allowed to step into, for example, the emergency department. They may have to just stand at the door as sort of a figure of menace, I suppose. But, less of a practical support if a patient is offensive, verbally aggressive, violent, causes difficulty for the staff. We are going to have to do more thinking and more talking about that, not less. And I guess I'm jumping ahead a bit, but in terms of thinking about cultural safety and how we practice that, I'm also concerned that while there's some really great materials, Te Ora worked with the Council of Medical Colleges, the Medical Council, they have produced some really great material, but increasingly what Te Whatu Ora offers is online training, and I think a number of the colleges do too, do this online unit. That precludes the kinds of conversations that I think people need to be supported to have that will actually prepare people to respond in the best way when they are put in these difficult situations. So I think while an online component might be reasonable in terms of some training and support, that shouldn't be all that is provided or expected.
Yeah, because like Sam was saying, and like you've started to talk about, the employer has obligations for staff safety.
Absolutely.
So would you be able to talk to us about what those obligations look like?
Well, it's really interesting because if you think about workplace health and safety, and particularly psychosocial health and safety, that is not an area that employers are typically as good. Slips, trips and falls, got that covered. Moving heavy patients, got that covered. But psychosocial safety is much, it's more difficult to define, it's more difficult to deal with. But I think culturally safe practice, there's plenty of work that's being done, as I've already alluded to, and it is a matter of employers stepping up and supporting staff to have those whole of staff discussions. These are the types of things that should be a standing item in staff meetings. People should be offered scenarios. The sort of discussion that we're having here, some of the examples, there will be examples that exist that hospitals will be aware of, that will have happened, that they could reasonably workshop with staff.
Yes.
Because for all that people hate role play, actually dealing with scenarios is a really good way to upskill and to learn, and also to see something play out and think, oh, what if you tried this? What if you tried that? And I think doctors often deal with those as part of their examination processes, having to deal with those simulations. I think we should be looking at that, and we need to be including the security staff, the reception staff, healthcare assistants, all of those people. They need to be cross-profession discussions about how we deal with those things.
Yeah. So, because the employer also has absolute rights about, for example, the Employment Relations Act and the Bill of Rights, do they come into play at all here, Adam?
Getting down to brass tacks is whether or not a request like, I do not wish to have clinicians of some ethnicity involved in my care, is that something that a patient is entitled to express under the code and have that desire accommodated if reasonably possible? From the patient's perspective, I guess they would be relying on Right 7, paragraph 8 of the code. Every consumer has a right to express a preference as to who will provide services and have that preference met where practicable. My view is, and this is something that I'm sure you could spend a lot of productive time thinking and writing about. So with that caveat that I haven't perhaps had as long to think about it as I would have liked, I don't think that it would be a permissible interpretation of the code to read 7.8 as accommodating, allowing patients to express a preference about race as a blanket thing. So I think, Sam, you said earlier that it's worth investigating why the patient has expressed this view. I would probably take it a step further and say that needs to occur. There needs to be some interrogation of why it is that the patient has said that they don't want to be provided care by people of a certain ethnicity, because there might be something clinically relevant behind that, or something personal to that person that it is legitimate to take into account. I think the example was given of PTSD or something like that. But let's assume for the moment that step's occurred, and this is not driven from a clinical fear or mental unwellness or something like that, but it is just a racist belief. If it's a racist belief, then the code does include a clause 5, which provides that nothing in this code requires a provider to act in breach of any other duty or obligation imposed by any enactment, or prevents a provider doing an act authorised by any enactment. So it's a way of trying to say that the code won't take precedence over other laws. Now, to be fair, the framework for human rights, anti-discrimination in New Zealand is complicated, and lots of the laws try and find ways to fit them into a hierarchy. And this is not, I don't think, from the time I've spent looking at it, that this is a particularly straightforward scenario. But from my perspective, I would be saying that the New Zealand Bill of Rights Act does provide that everyone has the right to freedom from discrimination on the grounds of discrimination in the Human Rights Act. That includes race. And that's the starting point. People, if they were to make a complaint, let's say, to the HDC to say, I made this request to not be cared for by doctors of a certain ethnicity and nobody listened to me, the response that I would assist with would be to say the HDC cannot interpret Right 7 Clause 8 in a way that makes that a legitimate request that doctors have to respond to. Doctors have a right not to be discriminated against, and ultimately, if that were to go to court, that would be the argument that would run. And I think it's such an important point of principle, because if you accommodate it for just a plain racist belief, you've taken a step down that road. And where do you then draw the line? I mean, it might be easy to say, gosh, wouldn't it be just conflict avoidant if we all just reorganised the shifts a bit and gave this person what they wanted? Once you've done it once, don't you then have to do it again and again? And it erodes a really important principle that we try and organise our society by. But it is complicated, and it's not a case where, for example, the Human Rights Act provides a really clear answer, because the way that's written is to create obligations on employers and people who provide goods and services, not the people who are asking for them. You can, in the private sphere in New Zealand, discriminate. You can choose not to associate with people if that's your worldview, and the laws has nothing to say about that. And so it's a slightly odd fit when you're talking about someone who's requesting a good or a service in a racist way. The Human Rights Act doesn't apply to that situation in a straightforward way, but I think the simpler answer to me is just to say you have to interpret the HDC code in a way that is consistent with the New Zealand Bill of Rights Act. The consistent reading of Right 7.8 is that it is not a legitimate request to make that you do not wish to be cared for by people of a certain ethnicity, unless there is a proper foundation for that, which you already would have interrogated and learned about if you've taken that step.
So are you saying that, I mean, obviously the patient is entitled to request whatever they like. It's up to the agency or the hospital or clinic to decide what they do with that. So am I hearing you right to say that it's the employer or the entity that needs to give effect to the Bill of Rights and and human rights? Is that what I'm hearing?
Well, this is why I don't think the law is a reasonably poor fit for this situation. I don't think that the person making the request has done anything wrong, morally perhaps, but not legally. You're entitled to express that racist view if you wish. I think that both the person they expressed it to and the service would have a good defence to an HDC investigation if they said, look, we are not in the business of accommodating requests like that. Our staff are who they are, and you can ultimately refuse, of course, informed consent to have someone provide care to you. We're not going to force this care on you, but if you wish medical care from our team, this is our team. So it's more of a defence that you would have against that complaint. There may be, if the service made a decision to accommodate it and rather than individual clinicians, if the management said, well, we're going to accommodate this request, well, then the employees may have a claim against the employer potentially. Not something I've looked at closely, but that is, in a sense, a form of discrimination from the employer against the employee. But again, it's not a great sort of fit with the laws that we have, which are really targeted at discrimination around being offered a role, as opposed to once you're in a role, who's going to be put forward to fulfill certain duties if there's a choice. And look, employment, again, another caveat, lawyers are great at that, but is not my key area. So I would defer, I think, to ASMS on that.
Yeah. Sarah?
Well, I was just interested in what you said, Adam, about if the management made a decision about care must be offered in a certain way, or we're going to concede to this patient request that for whatever reasons, but based on ethnicity preference, then I still think all of the stuff I was saying about having protocols in place, communicating clearly with employees, making sure staff are okay, understanding what that means for people, because to me, that would be a struggle,
Yeah. Well, there's an obvious moral injury there. If from let's say it's a nurse's perspective, they're prepared to go ahead. They know this belief has been expressed. They've taken the view that it's not a legitimate one. They're the person on shift. They're there to do the work. And then someone else comes in over the top and says, actually, I'm taking you out and swapping you with somebody else. That to me doesn't feel right. And I haven't looked into what the legal consequences of that might be. But as I say, it doesn't feel right. And as we discussed right near the beginning of the podcast, all of these ideally are things that will have been thrashed out well beforehand and captured in a process or a protocol that people are aware of and are signed up to and have had the opportunity to discuss and take on board before they're presented with a really tricky situation like this.
Hard agree, although I suspect that's not the case out there in the real world.
Absolutely, and I think that's really interesting that you say that in the commentary around Right 7-8. It's really important for us to understand, because there have been some opinions that I've heard that says that Right 7-8 gives the patient a right to express. And of course, like Sam says, they can ask for whatever they like. But from the provider's perspective, whether they need to accommodate that request, if it's purely a racist request, for example, it's good to know that it's provided for in the code under Clause 5, and that it's stipulated that there are limits placed on these, that it's not an absolute right to make that request.
I mean, it's expressed in relatively absolute terms, and you can imagine that perhaps when Right 7-8 was being drafted, it didn't occur to the drafters, perhaps, that people would be making or expressing preferences like that. But when faced with a complaint, I would be reasonably confident that the HDC would not swiftly move to find someone in breach for not accommodating the express of a racist preference. Just at a practical level, I don't see that sort of complaint moving to investigation and then going on to a breach. I think the HDC will be trying quite hard to just stop it at an early stage. If it did go on, then the arguments that can be made is that you, the HDC, as a public body interpreting this document, must do so in a way that's consistent with the New Zealand Bill of Rights Act, where such an interpretation is available. It's plainly available in these circumstances. It should be interpreted in a way that accommodates and is consistent with the right people have not to be subject to discrimination on the basis of race. And if the HDC were brave enough to disagree with that, which I doubt, not necessarily because think that it's the more powerful legal argument, but even just on on a cultural level, the culture of the HDC, I don't think would be wanting to come out swinging in opposition to that sort of argument. But let's say they did. I imagine it's the sort of thing we would want to take to court on judicial review.
Similarly, I think if management were repeatedly putting staff in a position where they felt unable to do their jobs on grounds of ethnicity or whatever reason, I would expect that there are some workplace health and safety issues around that, but I think also there might be grounds to take a personal grievance on the basis of discrimination. And certainly as the union, we would be really unhappy if we found that out there that was what was going on in any hospital settings. And we would at the very least want to have a discussion with the employer about what was going on and why, and talking to them about how they might best change their practice.
I think it is, like you say, it's a difficult situation, and what's being mentioned a lot is exploring what's underlying that request from the patient. But actually, at the end of the day, or talking to some psychiatry colleagues, they have said that it's really rare and almost unheard of for them in their careers to know that a patient has a fundamental psychiatric cause that's led to a psychiatric condition, which means that they cannot tolerate or experience significant distress from being in contact or receiving care from an entire ethnic group. Like, it's usually one specific individual, and if another individual fits those characteristics, then they might experience a reaction. But I'm not a psychiatrist, but that's their perspective. And a lot of the time, unfortunately, there's been lots of these cases, and I've talked to a number of nursing colleagues who have said that often their shift schedule is changed because a patient has said, I don't want to be cared by staff of a certain ethnicity because previously I received care and they weren't nice to me, and now I'm distressed by that entire ethnicity.
So without any consultation, rosters are just changed?
Commonly.
So, the thing is, hospitals are melting pots, right? You've got heaps and heaps of people from all kinds of backgrounds, socioeconomic, cultural, ethnic, language, staff and patients being pushed together in difficult circumstances because very few people are having their best day when they're admitted to a hospital, right? So it seems to me that, and there are aspects of cultural safety where attention is being paid that we see, but I think in all of these situations that we're talking about today, attention is not being paid in a proactive, preventive, supportive, educative way for staff, and that is it's an area of work. So, I'm going to go back and start some conversations, but it's something that I think people shy away from because it sits firmly in the difficult conversation zone, which is a stronger reason to do the work. But that is terrible if people are just being mucked around with their work patterns.
Frequently, I'm told.
For a very shoddy reason, I would have said.
I'd be interested to know which ethnicities that happens to, whether it's across the board. I don't know whether any patients would enter a hospital in New Zealand and say that I don't want to be seen by anyone of Caucasian origins. I don't know whether that happens or not, but would that be accommodated in the same way as, say, if you're Asian or Pacific Islander or Māori? I'd be interested to know. I mean, I have no idea, but yeah.
I think it's quite disappointing to learn that it would happen, shift changes would happen in a relatively offhand way. It's perhaps another symptom of a resource crisis in the public healthcare system, because you can imagine that actually sitting down and managing these issues in a really mindful, considered, careful way takes time. And if people are struggling just to prevent injury and death in hospitals through lack of hands, then they might take the path of least resistance and say, look, we're just going to do this because it's the simplest thing to do that's going to require the least amount of my time to manage, rather than going and spending half an hour with this patient, calling in support person from family to resolve the tension. So that will perhaps be part of it, and also higher acuity patients being cared for in inappropriate parts of the hospital. So, general med wards getting full of psychogeriatric patients who don't have appropriate beds to go to where they can receive psychiatric care and are being cared for in wards and by teams that are not geared up to actually provide that sort of attention.
Can I be awkward and just change the scenario slightly? Just following up from something you said, Sam. So what if this was a Māori patient who came in and said, I'm aware that my outcomes from the research that's been done are likely to be better if I have a Māori provider rather than a white provider or some other provider, and I'd like to request a Māori provider if that person's available. How does that one sit?
Yeah, I thought about that this morning when I was biking to work, and it is the riposte. It's the, if on the one hand you've got a sort of a racist request made by, let's say, a Caucasian person to not have a clinician of a certain ethnicity, the mirror of that is someone saying, look, I would feel better supported, more culturally safe, etc., of having a clinician of the same ethnicity as me. And that did give me pause, but I think you have to be consistent to a degree. I think it would be fine in the example of the racist situation to say, look, these are the staff we've got. That's not a request that we're able to accommodate. But if you want a support person here, or if there's some way that we can make this provision of care feel safer for you or less distressing, we can talk about that, whether that's a family member, or we can have an HCA in the room or whatever. I think my preference would be, and it's definitely an idea that's worth discussion and testing, and I wouldn't necessarily hold to this after such testing, but my initial thought was the better way to handle that situation is, no, look, we're not going to change rosters or pull in people from another team, but we hear your request. What are the things we can do in addition to make this feel like a better provision of care for you, and to make you feel comfortable that you are being treated appropriately. That was my initial thought on a bicycle at 7:30 this morning. So it's not with hours of thought behind it, but that was my initial reaction to that scenario.
Cheyenne, you working at DHB, do you think that's the kind of request that a DHB would say, actually, that's reasonable? We do have Māori staff available who could be involved in the care. That's an appropriate request, given that there's a scientific basis to the request.
Yeah. And actually, that's happened, and that request was accommodated. But unfortunately, not all staff were able to be Māori. And unfortunately, that one person that wasn't was discriminated against by the patient. So it's not a perfect answer to your question, but I think the difficulty is when you start thinking about people in those terms, it just moves into grey areas very quickly, and that there's that social overlay and our expectations. Who knows why they're really asking? They're really well informed, and
So can I? So
It's
I
just
think.
difficult.
So I think one response might be that absolutely statistically you're right. Unfortunately, Māori experience healthcare later and with worse outcomes than non-Māori. The fact that you're here in hospital with a diagnosis and an opportunity to be treated it means you're in a different place from that statistic. But also, where we have, if you have a Māori liaison person or staff who can support, we're really happy to get them in to see you as soon as possible. The statistics about Māori doctors, for example, there are so few that the chances of someone being able to be seen necessarily by a Māori doctor aren't that great. Even in a large hospital, you may have, and the other thing is you may have registrars, but you may not have consultants. So I think, again, being able to have those conversations, and I think when you talk about culturally safe practice, often people assume it's about Māori and non-Māori, but actually it's not. It's about understanding who you are and what you bring and how you engage with all of the different people that you encounter in your work life, both colleagues and patients. And so, again, I would say we often shy away from these conversations, even as colleagues, because we're worried that we ourselves will be deemed racist if we don't express a question or a concern in an appropriate way. And so, we don't do the work before that happens. So, the fact that Māori should be accessing bail screening earlier than non-Māori, or the fact that if you're a Māori male, you're far more likely to be misdiagnosed for your cardiac event or not offered care. And there are some horrible paediatric stats that we were given at a meeting the other day in terms of diagnosis and care offered to Māori babies compared with non-Māori. They're horrible, right? But if you've got someone, and so we've got, as a system, we've got work to do. But if you've got a patient in front of you, it's like, well, you're here now. We have a diagnosis. We have a care plan. Here's the people that we can bring in to support you so that you do feel culturally safe and cared for through your journey. And we're really open to listening to what you want or what you think might be beneficial. But you also have to understand that you're in a public hospital. We don't even have enough doctors on today, let alone enough doctors who are Māori.
And I think you've got to be consistent. If you're going to be prepared to be tough on the racist person not wanting brown doctors looking after them, I think the right thing to do in that scenario, Tim, is to take that same first principled approach. Say, look, we don't, expressing a preference in that sort of way is not something we can accommodate in the public hospital service, but what we can do is, and then all of the things that Sarah said, or also having the time to explore what is it that is your worry or concern, how do we address that? How does the doctor you're given meet your needs rather than you get to pick and choose your doctor?
Oh, because I'm much more comfortable in talking in te reo rather than English.
Well, that's a different thing.
Yeah.
That is a whole different thing. So, and I think translation services.
Yeah, but I don't want a translator. I don't want to be able to talk directly to my provider who's
that's great, but the chances of finding a fluent Māori-speaking, fully qualified specialist are going, unfortunately,
vanishingly small,
are going to be slim. And so if that person exists and they're available, that's lovely, but I think we need to be really clear. But I think there's a lot of miscommunication in busy hospitals, understaffed hospitals, and I know that access to translators is often really challenging. And I have also heard views expressed in internal meetings of that frustration of it's just too hard, and I'm sure that leads to suboptimal outcomes for a number of patients where that communication is poor for whatever reasons. So, there's lots for us to do.
I think what I'm hearing is, if you take it back a little more and take ethnicity out of it, for all of our patients, we want to be providing appropriate care where patients do feel supported, where they're getting the information they need in the form that they need it, and all of those things giving effect to their rights across the board. And it doesn't matter what it is that they're after, whether it's to do with who who's providing their care or whether it's to do with, I don't know, something else that they need. It really is about we do what we can, and but that's always going to have limits.
Absolutely. And I think if you are in the position where you're thinking about accommodating the request, I think because of all the reasons we've talked about, it's got to be a really clear, justified reason that, and your management plan should be clearly communicated to all the staff affected, potentially affected. Because I think that's what, because as clinicians, we all understand if someone has a particular request, say a patient comes in through ED and that they've got a management plan because they have particular requests every time. And this is what it's got to be like, a clear management plan with the reasons and how we're going to do this. So no one's kind of kept in the dark or just pulled from their shift or subbed in out of the blue.
I do think, though, that if you are routinely, your shift has changed for what I would say is a shonky reason, a terrible reason, and also without it being communicated to you, or if there aren't protocols that exist, talk to your union and talk about how you're being mucked around in your workplace and that you're not being supported to do your job appropriately, because it may be being pulled off shift or change ward. You're no longer working in your preferred area or the area in which you've done training. I vividly remember when my husband was admitted for a broken bone and ended up through overcrowding in the cardiothoracic ward. He was just surrounded by all these really sick old men, but the nurse was like, wow, haven't done bones, this is exciting. But I was just like, maybe. But what does this mean for the kind of care that my husband was receiving at the time, And I knew, because before he'd got surgery, there was no room on the ortho ward and he was stuck in a cupboard. Now, it literally was a cupboard, like it kind of had some old furniture in it and stuff, It was just, so I know stuff like that happens all of the time that's not optimal. But if then on top of that, you are being mucked around as a staff member and no one's explaining to you what's going on, talk to your union, because there might be some conversations that they can have on your behalf. And if it's happening to you, it will be happening to others as well. That might change things for the better, at the very least open up some communication so people have a better understanding of why these decisions are being made.
So along those lines, can we, if a situation's happened, can we describe the situation to our union? Because it's involving patient care, we give some clinical details. I wouldn't have thought that constitutes a breach of the patient's privacy.
Of course it doesn't. If you're a healthcare worker and you're going to a union and you're talking about a workplace issue, you have to be able to describe the workplace issue. We find in the vast majority of cases we deal with either it has nothing to do with patients, or if it does, because there's a complaint or a competence issue or something of that nature, there may be some patient information that comes to us. Usually it's anonymised up to a point, or things are redacted, but sometimes stuff is missed out or it's not. So we just redact it ourselves, or we just take what we need and ignore the rest and make sure that whatever is kept, if it does need to be kept in our records, any patient details are redacted or have been. So, but of course you have to be able to talk to your union, and we will maintain that confidence. We're not going to go blabbing, but we have to be able to make sense of what is going on for you. And so that sometimes involves describing, what happened at work today or what happened in a series of events that led to this point. Everyone's
entitled to get advice, to get their own advice, aren't they?
Yes, yeah.
Coming back to some of the comments that Sam and Adam made before, just one area I'd like to explore a bit further, because you both emphasised the need for someone to explore the reasons why this person made the request or the demand. I don't want to see a provider of this ethnic origin. Who does that inquiry? So it's not appropriate for a receptionist to do it, I don't think. It's not going to be the doctor of the ethnic origin who should do that. Who in an organisation would do that kind of inquiry and find the reasons, if there are any?
There are some hospital ethics committees. They have, if it's a non-urgent situation and the patient feels strongly, there are some hospital ethics committees who can hear both sides, and some of them have lay people on them who can advise. I know our one is run, and some of them have psychiatrists. So, and also, I think a consideration can be made for a psychiatric assessment if they're saying that it's caused them significant distress that's impactful. Then is it reasonable? I think it might be reasonable to get a psychiatric assessment.
If they accept it. And I presume in an ED situation where it's urgent, there'll be managers a lot of the time in most EDs who might be able to do that or not?
Not on the floor. There's usually a lead charge clinician who might be able to do that.
I wonder, though, if you're going to train all of your staff and you have a policy that applies to all of the staff, I would have thought, in fact, that the staff member would be able to ask the questions. And it doesn't matter whether they're a clinician or part of the admin staff, etc., etc. I would have thought, in fact, that it would be open to whoever the person is that the patient happens to have mentioned their concerns to.
So speaking of clinical ethics, I think given that Te Whatu Ora is a national organisation now, there would absolutely be the potential for senior managers, clinicians and clinical ethicists to work through some of these issues, to take some cultural advice and feed that into a bit of a national guideline and a protocol that staff and unions can have input into, and that would then be a framework on which, you'd be able to hang some of those local scenarios and be supported to work your way appropriately through those situations as they arise.
Yeah, absolutely. So for now, because it's such an interesting topic, we're going to finish this part of this discussion, and there will be a part 2 for this topic. And thank you for listening to this podcast, and I hope it's been helpful and interesting. We look forward to catching up with you in our next podcast. If you like the Medical Protection podcasts, please subscribe and leave a review. If you would like a podcast on a specific topic, please email nzpodcasts@medicalprotection.org.